All right, if you're a nursing student and you're getting ready for your next big PHARM exam, you are in the right place. Today, we're doing a super high-yield review of a med you absolutely have to know, inside and out, nifedipine. Look, we get it. Pharmacology can feel like trying to drink from a fire hose, right? So for this review, we're going to use the 80-20 rule. We're going to focus on that core 20% of info about nifedipine, the stuff that's most critical and most likely to pop up on your exams to get you 80% of the results you need. Let's do this.
So here's our game plan. We'll kick things off with the essentials, then dive into how it really works. After that, we'll cover safe administration, what to watch out for, and wrap up with the absolute do-nots. By the time we're done, you'll have a rock-solid grasp of this drug. Okay, first up, the essentials. So what is this stuff and what's its job in the body? Nifedipine is a dihydropyridine calcium channel blocker. Now, I know that's a mouthful, but the key word you need to lock onto is dihydropyridine. Why? Because that word tells you where it works. See, unlike some other calcium channel blockers that mess with the heart's electrical system, dihydropyridines like nifedipine focus mostly on the vasculature, the blood vessels. Just think of them as powerful vasodilators. Their main mission is to relax and open up the arteries. So what's this drug supposed to accomplish? It really has two main gigs. Number one, lower blood pressure, and number two, get more oxygen to the heart muscle. And that directly explains why we use it. For hypertension, well, it lowers blood pressure. And for angina, that's chest pain, it widens the coronary arteries, letting more oxygen-rich blood flow to the heart. It's really that simple.
Okay, so now we know what it does. Let's peel back the curtain and see how it does it. This is section 2, the mechanism of action, made easy. We're going to break down exactly how nifedipine gets the job done. I want you to think of it like a simple 4-step domino effect. First, nifedipine comes in and physically plugs up the little channels that let calcium into the smooth muscle cells of your arteries. Simple enough, right? Well, without that calcium, the muscle just can't squeeze and contract, so it relaxes. That relaxation makes the arteries get wider. That's our vasodilation. And when the arteries are wider, there's less resistance, which means, you got it, the blood pressure drops. It's a direct chain reaction. And now we get to the part that is all about your nursing practice, safe administration. This is where patient safety truly starts. Listen up, because this is probably the single most important administration rule you need to know. Sustained-release tablets must be swallowed whole. I'm serious, they can never, ever be crushed, broken, or chewed. And here's the critical reason why. Crushing that tablet destroys the special coating, which means the entire dose gets dumped into the patient's system all at once. And that can cause a sudden, severe, and really dangerous drop in blood pressure. This is a non-negotiable safety point you have to drill into your patients. All right, let's run through a few more key rules. First, let's talk food. The specific brand called Adalat CC, that one needs to be taken on an empty stomach. Other forms, they can be taken with food if they're causing some stomach irritation. Now for dosing, you'll often see the sustained-release versions starting at about 30 to 60 milligrams once a day, and then the dose is adjusted from there. The key is always to start low and go slow, especially with older folks. And here's a common patient question you'll get. They might see what looks like the pill in their stool. You need to reassure them that this is totally normal for the extended-release forms. It's just the empty shell. The medication has already been absorbed. And one last thing, a little bit of an old-school practice. Giving nifedipine under the tongue sublingually is not recommended anymore. It's not safer, and it doesn't really offer any benefit. This is one of the most famous food-drug interactions in all of pharmacology, and for good reason. It's a huge deal. Grapefruit juice can literally double the amount of nifedipine floating around in the blood. How? It blocks an enzyme in the liver that's supposed to break the drug down. So with twice the medication circulating, the patient is at a massive risk for severe hypotension. This is an absolute must-teach point for every single patient on this drug. Okay, so we've given the drug safely. Great. Now, what do we need to be watching for? This is your guide to adverse reactions. So, the most common side effects are all directly tied to that vasodilation we talked about. It just makes sense, right? When the blood vessels all over your body widen, it can cause dizziness, a feeling of warmth or flushing, and a headache. And these are pretty common. We're talking up to a quarter of patients might experience them. It's so important to let your patient know that these might happen so they aren't totally freaked out. Okay, let's get tactical and break down 3 key side effects and what you, as the nurse, are going to do. For peripheral edema, that's swelling in the feet and ankles, your job is to assess for fluid overload, monitor their daily weight, and teach the patient to elevate their legs.
For hypotension, which usually shows up as dizziness or lightheadedness, your main roles are monitoring their blood pressure and teaching them about orthostatic safety, changing positions slowly. And finally, here's a weird but testable one, gingival hyperplasia, which is just overgrown gums. Your number one intervention here is education. You have to stress the importance of excellent oral hygiene to help prevent or manage it.
All right, we've made it to our final and honestly most critical section, who should absolutely not take this drug and what other drugs could cause a serious problem.
There are 3 major contraindications you have to burn into your brain. The first 2 are pretty much common sense, right? You never give a drug to someone with a known allergy to it, and you never give a blood pressure-lowering drug to someone who is already severely hypotensive. That's just pouring gasoline on a fire. But the third one is a bit more subtle and really important. You've got to be extremely cautious giving this to patients with heart failure. And that's because nifedipine can have a negative inotropic effect, which is a fancy way of saying it can slightly weaken the heart's pumping action. For a heart that's already struggling, that could be dangerous.
Hey, remember that whole grapefruit juice thing we talked about? Well, this slide shows you the science behind it. It all comes down to a liver enzyme called CYP3A4. Think of this enzyme as the cleanup crew for nifedipine. Now, things that are inhibitors, like our friend grapefruit juice, they basically tie up the cleanup crew. This slows down the drug's breakdown, causing nifedipine levels in the blood to rise, and that risks toxicity. On the flip side, things that are inducers give the cleanup crew a shot of espresso. They speed the enzyme up, breaking the drug down way too fast and making it less effective. If you can really get this inhibitor/inducer concept down, you'll be able to predict a ton of drug interactions.
Okay, let's wrap this all up with a quick clinical scenario to put all the pieces together. Your patient is on nifedipine. You check their vitals and their blood pressure is 92/58, and they're telling you they feel dizzy. What is your immediate nursing action? Think about it. What's the very first thing you do to protect this patient? Answering questions just like this is what takes you from just memorizing facts to thinking like a great nurse.